This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. Welcome to Monday Cardiovascular Grand Rounds. This morning, we're very pleased to have our own Dr. Robert Guyton speak with us. As you know, Robert is the Chief of Cardiac Surgery, CT Surgery here. He is the Hatcher Chair as well. Robert graduated from Harvard Medical School a few years ago, did his surgical training at the Mass General, and was chief resident at the Boston Children's Hospital. As you know, Robert has been a major figure in cardiovascular surgery for quite some time and has numerous honors, including past president of the Thoracic Surgery Society. His CV lists, I guess, a little over 200 publications spanning everything from ischemia reperfusion injury, surgical outcomes, and some of the newer techniques. And as you know, is actively involved in our TAVR program here. And it's a real pleasure for Robert to tell us who is inoperable. Probably nobody, right?
Thank you. We've made great progress in the last 20 or 30 years. Coronary mortality has decreased since I came to Emory from 5% to 2%. Valve mortality from 8% to less than 3%. Stroke rate from 3.5% to 1.2%. We now repair valves that formerly were discarded. Patients with ejection fractions of 20% were inoperable in the past, and it's commonplace now. We put in left ventricular assist devices, and we send the patients home. But perhaps the area in which we've made the most dramatic progress, at least in the last few years, is our transcatheter valve effort by putting expandable stents in the aortic valve with catheters transfemorally, transapically, transaortic, and transcarotid here at Emory. And we operate on incredibly sick patients, sicker and sicker patients. This is a patient that would have been turned down just 5 years ago, 87 years old, FEV1 of 46% of predicted, peripheral vascular disease that was symptomatic, X-ray therapy to her chest for cancer. Would not have been operated on. This patient underwent a transaortic transcatheter valve. This is another patient, an STS predicted risk of mortality of 13%. Again, severe COPD, good ejection fraction, but again, peripheral vascular disease, frail, refusing blood transfusions, and a porcelain aorta en route, underwent a transapical transcatheter valve. This is another example of what we've been able to do. 27-year-old male, severe aortic regurgitation, 6 previous sternal thoracic operations, including a mitral valvuloplasty, a mechanical aortic valve replacement, a Ross-Cono procedure, that failed, then a homograft root replacement in 2008, and then severe aortic insufficiency in 2012, underwent a transcarotid transcatheter valve. And here, probably pushing this to the limits, is a patient with a 37% predicted risk of mortality, 69 years old, young and pretty good looking, and that's the reason that he had his operation, but had very severe COPD with an FEV1 of only 20%, a DLCO2 of 20%, in part because he had some pulmonary edema, but not terrible pulmonary edema when these pulmonary function tests were done. Previous coronary disease, a good ejection fraction, severe aortic stenosis across his bioprosthetic valve, and a 23 millimeter bioprosthetic valve, which meant when we put the transcatheter valve in, he still had a gradient, but not a 67 millimeter gradient. Previous tricuspid and mitral repair, and severe pulmonary hypertension, underwent a transfemoral valve-in-valve in the aortic valve. So we can perform this procedure in almost any patient. This leads to things like this. A celebration. I was in Jalisco's restaurant in the winter of 2012, and in walked Mrs. X, an 87-year-old, 7 weeks after her transaortic transcatheter valve. One of Emory's first commercial sapien valves and the first transaortic sapien TAVR in the United States. And Mary's not her real name, Michael. This is a fictitious name. So and they said, Dr. Guyton, we're so grateful. Mary can get out and can enjoy life for the first time in years. It also leads to this, however. The same winter of 2012, a family conference with the wife, son, daughter, and granddaughter of Mr. Y, 6 weeks after a transapical transcatheter valve, with PA pressures that were 3/4 of systemic pre-op and never came down post-op. He was functional class 3 pre-op, driving, walking, and so forth, now in our ICU dying after 7 weeks of right heart failure. And they told me, Dr. Guyton, we never would have done this if we realized this could happen. We can operate on almost everybody, but should we operate? What are the limits, and how do we assess risk? More importantly, how do we assess risk and benefit? We need to be patient-centered, efficient, and effective. We need to do the right procedure in the right patient at the right time for the right reason, and we certainly can do better. The risk-benefit analysis must be more expansive. It's not just the procedure, it's the whole patient. We talk about benefits in surgery, and we talk about survival and relief of symptoms. What we haven't talked about for years is the other risk of intervention other than death. Things like new disability, stroke, and wound problems. We don't talk especially about failure to relieve symptoms, that is continuation of disability, which is a big problem when you get to the 75 and 80-year-old. You put them through the surgery, but they still can't get out of their bedroom or get out of their living room. We also don't talk about short-term recovery symptoms or disability, especially in more invasive procedures. And when I talk with patients now, I try to talk about not one, but 3 major outcomes. First, I put death or major stroke in the same bucket, because as far as patients are concerned, they are in the same bucket. We talk about death or major stroke as one outcome, a catastrophic outcome. I talk about survival with benefit, which is the desired outcome. They go through the operation, they get better, and they've achieved their desired outcome. But then survival without benefit, that is survival without improvement in symptoms, is the third category that we don't discuss, that we need to talk about more. These are 2 examples of this expanded risk-benefit analysis for an aortic valve replacement, for a standard aortic valve replacement, not transcatheter, an 80-year-old patient with aortic stenosis, class 3 symptoms, not deconditioned, and secondly, the 80-year-old patient with aortic stenosis, class 4 symptoms, deconditioned with the previous stroke. In the first patient, the 80-year-old, not deconditioned, the objective is quality of life and prolongation of life. The risk of death or stroke is about 3%. The chance of survival without benefit is there, however, in the 80-year-old. Occasionally things come up, occasionally they may still be class 3 because they may have had pulmonary problems, renal problems, liver problems during the course of their surgery. So there's some chance of survival without benefit in this group. A wound problem could keep them in and out of the hospital for the next year. All of these low frequency but present negative events can occur. So the chance of survival with benefit in this patient is about 90%. This patient does have short-term recovery symptoms for about 6 weeks. These short-term recovery symptoms, that is disability for 6 weeks, generally are much better accepted by an 80-year-old than they are by a 40 or 50-year-old. The 40 or 50-year-old says, why can't I get this done in 1 week? The 80-year-old is much more accepting of the fact I'm going to be down for about 6 weeks. Now, what about the 80-year-old with class 4 symptoms, COPD, previous stroke, ejection fraction 30%, and deconditioned? The objective here for this patient is quality of life, not so much length of life. They say, I really just can't enjoy my life. I need to be able to walk to the mailbox. I need to be able to get up and walk out in the yard. I want to see my grandchildren and walk around with them. Here, the chance of death or stroke in this patient by the STS risk predictor is about 15%. The chance, however, of the patient coming through the surgery and never regaining his or her vitality is real, and it's up in the 1/3 rate if you start off with a deconditioned 80-year-old patient. And perhaps the chance of survival with benefit is 50%. And we don't have a good handle in particular on the numbers in the survival without benefit class. The recovery symptoms are prolonged by the deconditioned state and the need for rehab. So this is this simplified risk analysis in the patient-centered paradigm. On the left, you see the 80-year-old with a 90% chance of survival with benefit. And then you look at the 80-year-old with the stroke, COPD, deconditioned, and the chance of survival with benefit in this patient is probably 50-50 or a little worse. And so here you have a serious discussion with the patient and the family. Do you really want to do this? Once you hit the 50% plus or minus, then it's a real problem as to whether this is something that you want to put them through. You're not just putting the patient through it, you're putting the family through it. And you can destroy a family by having a patient in the hospital for 3 months. Destroy them financially, destroy them emotionally. It's a major concern. So these are things that we really need to consider. In one case, we have a 6-week recovery. In the other case, a 12-week recovery. So perhaps this has been our thought all along, that this is where the percutaneous treatment might best fit in, that perhaps we can reduce this. We know that the absolute survival, at least from the early studies, was about the same in the surgically suitable patient in the 80-year-old undergoing a standard procedure versus the transcatheter procedure. But our thought has been that survival without benefit was much lower in the transcatheter group than in this deconditioned patient. So the obvious and immediate utility seem to be patients who currently have a high chance of survival without benefit. So let's go back and talk about how good we are at risk prediction, what numbers we might have about survival without benefit, and where we are. First of all, risk prediction. There are 2 major risk predictors in use: the STS risk calculator, which gives you an STS predicted risk of mortality, and the Euroscore. The logistic Euroscore is used more than the additive Euroscore. These take, in the STS's case, about 35 fields and predict the risk of mortality, the risk of prolonged ventilation, the risk of a major morbidity, the risk of a prolonged hospital stay. The Euroscore is designed to predict mortality. This was a study from Dallas in which Todd Dewey looked at a series of patients undergoing aortic valve replacement and looked at the patients in the top 90% of risk and applied the STS risk predictor to their preoperative condition and then looked at the actual mortality. They predicted a mortality of 13.3%. The actual mortality was 18.8%. In his series, it was somewhat under-predicted. The Euroscore, however, in these patients predicted a 51% mortality, and the actual mortality in the Euroscore group was 15.6%. So the Euroscore dramatically over-predicted in these high-risk patients. The problem is that we're dealing in these patients with infrequent and serious comorbidities that are hard to fit into predictive algorithms. In the STS database, for example, only 2.5% of all the patients are on dialysis. So the power with which you're able to predict mortality in patients in dialysis is not nearly as good as the patients who do not have renal dysfunction. And less than 1% of the patients in the STS database had a recent stroke. So when you take somebody with a recent stroke and try to plug them into the STS database, your ability to discriminate and to have precision is very low. Now, this is an analysis of the Euroscore algorithm, review and meta-analysis of patients in published series from 26,000 patients in 12 studies. The average area under the curve was 0.73, which is borderline poor discrimination for operative mortality. The STS area under the curve in general has been predicted to be about 0.8 for isolated valves, a little better and probably acceptable, but both the additive and logistic Euroscore over-predicted operative mortality for isolated valves. The observed versus actual mortality for the Euroscore for additive was 0.89, for the logistic 0.6. For the isolated Euroscore, the observed over expected mortality was 0.54 and 0.45. And these we should be up in the 0.8 to 1.2 range as far as our what we expect to get from these risk algorithms. So the EURA score is not as good as the STS risk algorithm, and I think that's widely acknowledged. The problems with risk calculation is that it's adequate in the low to intermediate risk patients, but there's poor discrimination and precision in high-risk patients. These high-intensity and low-frequency comorbidities are very hard to include in the algorithms. And notable omissions from the risk calculators are severe organ system dysfunction and frailty, which are obviously intense comorbidities, but generally low-frequency comorbidities. Dr. Thrani looked at our patients at Emory, looked back for a looked back from 2002 to 2010, 1,800 patients undergoing AVR and AVR plus coronary bypass, including reoperations, had some 1,700 patients omitting emergency operations or concomitant valve surgery. And in these patients, he found severe organ system dysfunction in approximately 280, 300 of these patients. Neurologic dysfunction, that is a prior stroke, severe COPD in 85, low ejection fraction in 240, and renal dysfunction in 140. And this, when we sorted out mortality by organ dysfunction, looking at mortality over an 8-year period, we could see that the organ system dysfunction, renal was more predictive of death than pulmonary dysfunction, more predictive than cardiac dysfunction. Neurologic and pulmonary were about together. And when we looked at additive organ dysfunction, no organ dysfunction versus one organ dysfunction versus two dysfunctional organs, there was a clear separation between 0, 1, and 2. There were not many patients with 3 organs out. There weren't enough to do a statistical analysis. But in general, we've had a rule that we followed for years, or tried to follow for years, and that is if you have three strikes and you're out. If you've got 3 organ systems that are down, then that's probably too much. And that's the other problem with the risk algorithms, is we don't include the patients that we don't operate on. And so we have a large number of patients with high comorbidities that never make it into even the database when the surgeon feels or the cardiologist feels that they're not candidates for surgery. So we have trouble with those patients. The conclusions in this series, nearly 80% of the patients had low risk profiles, but the presence of renal failure most profoundly decreased survival, followed by severe COPD and stroke. Frailty has also been examined in the broader group of patients. Frailty in this study was defined, and I'm sorry I don't have the reference here, this was from Canada, was defined as a deficit in one of the CAT's activities of daily living or no independent ambulation or dementia. 41% of 4,000 patients undergoing cardiac surgery were frail, and frailty independently predicted mortality and discharge to another institution rather than home, with an odds ratio of 1.8 for the frail versus the non-frail patient. In transcatheter valves as well, the group at Columbia has looked at the frailty score in 159 patients, not a large group, particularly since in the partner database we have probably now 3,000 patients that need to be looked at. And this score included a 15-foot gait speed, grip strength, activities of daily living, and serum albumin. Found that patients with a higher frailty score greater than 5 had twice the mortality at 1 year compared to the patients with a frailty score less than 5. So frailty and organ system dysfunction, it seems, should be included in our assessment of risk, but we don't have the data yet, but it's time to begin making an attempt to include this. Now, what about survival without benefit? What do we know about this? And there's not much data, but there is some data from the TAVR data. This is a group of patients from Europe, 100 patients. They did assess frailty. 30% of the patients who survived had no improvement. That is, they had a mortality of about 14%. 30% of the patients that survived the procedure didn't get clinically better. They didn't get to functional class 1 or 2. In their group, the estimated GFR was the strongest predictor of non-improvement after TAVR. In a group from Germany, again, 145 patients, 23 died, but 17% more had no improvement in New York Heart Association class. They were class 3 or 4 to begin with. They were class 3 or 4 at 1 year and 2 years. And in their group, severe pre-op mitral regurgitation predicted the poor New York Heart Association response. So here we're beginning to look at what predicts survival without benefit. So we're beginning to creep into that area. And so in this study, 33% were either dead or not improved at 6 months. So what does PARTNER tell us? Now, PARTNER tells us that at 1 year, 24%, this is the inoperable patients, patients that either had a transcatheter valve or medical therapy. This is PARTNER B. At 1 year, 24% of the patients still were class 3 or 4. At 2 years, 17% of the patients were still class 3 or 4. And this, if we look at the survival curves, we see that at 1 year, about 29% were dead, and at 24 months, 43% were dead. So if we look at the additive death and survival without benefit, this means that at 1 year in inoperable patients, 46% of the TAVR patients were either dead or they were still functional class 3 or 4. This means that our desired outcome, which is survival with benefit in PARTNER, was achieved in only 50% of patients or so, which is a pretty sobering fact, that the comorbidities may be as important or more important than the valve itself. And this is, how do we begin to predict this? One prediction is by using the STS score, which is the additive comorbidities. And you see that the patients, this is in the PARTNER 1B trial, again, the patients with the higher STS score had very little survival benefit at 12 months or 24 months compared to medical therapy alone. So once the patient got up into that 30% range, there's a real question as to whether or not we made that patient's life longer or better, even with a transcatheter valve. And the advanced comorbidities seem to eliminate the benefit of TAVR, at least survival benefit, in this analysis of PARTNER. This is a commercial group from the France 2 registry. These are commercial TAVRs in Europe. And again, at 1 year, 30% of the patients were either dead or functional class 3 or 4. So commercially, we probably are doing a little better because the PARTNER trial pushes us to take people who are dying, that is the inoperable patients, and forces them into either surgery or transcatheter valves. But here still, we have a 70% survival with benefit with TAVR. And once again, you can predict using the Euroscore the additive effect of comorbidities. The patients with the high Euroscores were the ones that didn't do as well in this commercial TAVR group. What about survival without benefit with surgical AVR? We have precious little data, particularly in the high-risk patients, but we do have some data from PARTNER 1A, both for surgical and transcatheter valves, as far as recovery of symptoms. We see at 1 year in the PARTNER 1A trial, surgical patients, equal numbers, had a 13% class 3 or 4. The transcatheter valves, about 15%. Same at 2 years. So about 15% in both groups were still functional class 3 or 4 in the PARTNER 1A trial. We again know the mortality, and so we can say from that that the transcatheter valves at 2 years had a 44% chance of either death or functional class 3 or 4. The aortic valves at 2 years had a 42% chance of either dead or functional class 3. So essentially, about 47% of patients who have transcatheter valves have survival, 56% have survival with benefit with transcatheter valves, 56% with standard AVRs have survival with benefit at 2 years. And the same at 1 year. This is about 40% total death plus functional class 3 or 4. So 60% at 1 year in each group had survived at 1 year with benefit. Now there clearly is a difference between 0 and 6 months in that the surgical survival, the symptoms during this time, the surgical survival is less during this early period, and the symptoms are less during this early period. So the quality of life during this first year is clearly better with TAVR. But this is what I had estimated before when we did this risk-benefit analysis. The previous estimate, comparing this deconditioned 80-year-old with a standard procedure to the TAVR, estimating that the survival without benefit would be low in the TAVR group. And in fact, when you look at the 2-year data from PARTNER, it ends up, interestingly, about the same. And so here, this is our challenge. We need to sort this out a little better and figure out who needs to go for which procedure, but also recognize that the comorbidities are dominating the patient's course maybe more than the procedure that we're doing, and we need to be smarter about analyzing the comorbidities. And so this comes to what I'm proposing, looking at a little bit different view of how I assess risk, and including frailty and major organ system dysfunction. This was something that I worked on about a year ago as a preliminary to my participation in the valve guidelines group. But this is a general idea of how we might take patients and divide them into low, intermediate, high, and inoperable categories, and incorporate the predicted risk of mortality, incorporate frailty, incorporate major organ system compromised, and procedure-specific impediments. And this is what is the handout that I hope most of you have gotten. There should be some extra copies back there in the back, and there are extra copies on the front row as always, if you want some up here. So first of all, the STS predicted risk of mortality. The division here is STS less than 4, 4 to 8, and greater than 8. And how does this sort out? Dr. Thorani again looked at this. As the PARTNER trial was being put together, it was important to sort out what percent of patients are in the STS greater than 8. What percent are between 4 and 8? And indeed, we find out the patients with an STS predicted risk of mortality of less than 4 comprise 80% of the patients who've undergone AVR in the STS database from over a 9-year period. The predicted mortality in this group was 1.7%. The actual mortality was 1.4%. So about 80% of the patients that we've operated on over the last decade are in the low-risk group, and their actual mortality was less than 2% as a group. The intermediate group, this is an STS predicted group mortality from 4 to 8. This was about 14%. This was 14% of the total patients operated on of these 142,000 patients. The predicted mortality in this group was 5.5%. The actual mortality was 5.1%, so pretty close. And again, you see this is about 15% of the total patients that we have been operated on. The high-risk group was only about 6% of the patients that we had been operated on. The predicted mortality was 13.7%. The actual mortality, and this is using the Social Security death index, which we're no longer allowed to use, unfortunately, showed us that 11.8% was the actual mortality. So this is how it sorts out looking at the STS score. What about frailty? What are the indexes that we're talking about or proposing to use? We're trying to keep it simple. There are 6 CATS activities of daily living. That is independence in feeding, bathing, dressing, transferring, toileting, and urinary continence. and independence in ambulation. That is, no walking aid or assist, and a 5-meter walk less than 6 seconds. So they need to be able, 6 seconds is a pretty long time to walk 15 feet. And in general, they need to be walk 15 feet in 6 seconds and not require a walking aid or an assist. Major organ system is a little more complicated. And in here, we're talking about organ system dysfunction that we're not expecting to improve postoperatively. In the cardiac area, severe LV systolic or diastolic dysfunction, and particularly RV dysfunction and fixed pulmonary hypertension. Kidney disease, stage 3 or worse, pulmonary dysfunction, FEV1 less than 50%, DLCO2 less than 50%, CNS dysfunction, dementia, Alzheimer's disease, Parkinson's, GI dysfunction, Crohn's disease, ulcerative colitis, nutritional impairment, albumin less than 3, active malignancy, liver, any history of cirrhosis or variceal bleeding, or I would say also marginal synthetic function of the liver would also apply here. So in general, you're talking about organ system dysfunction that is sufficient to cause the patient some limitation in their activity. If there's organ system dysfunction, somebody's donated a kidney, their creatinine is 1.5 and they've got one kidney, that's not organ system it's not limiting their activity. When we're talking about major system dysfunction, we're talking about something that's this is a stroke with some residual disability, not a stroke with complete recovery. And finally, procedure-specific impediments. These are possibly allowed. For example, a tracheostomy, a heavy calcified ascending aorta, chest malformation or radiation damage, extreme obesity. We've all seen patients whose penis hangs 1/3 the way down the thighs and you can't get to the groin, and the opportunity to be able to sterilely access the groin is limited in the operating room when the patient lies down. That's what we're talking about with extreme obesity. And so this is where we come together with the low, intermediate, and high risk. But importantly, the question then is, what do we consider a prohibitive risk? Prohibitive risk. Who is inoperable? These first two items are from the PARTNER trial and other transcatheter valve trials. Life expectancy with successful operation less than 1 year. In other words, they've got comorbidities that even if the operation is successful, they're not going to live a year. That's a patient that probably should not be operated on. Secondly, and this is directly from the trials, chance of death or major morbidity, all cause greater than 50% at 1 year. And this is, all of these are debatable, but certainly I think that these are reasonable criteria. And then this, let's see, the chance of survival with benefit less than 25% at 2 years. By with benefit, I mean improvement of at least one New York Heart Association or Canadian Cardiovascular Society class, of at least one class, or improvement in life expectancy. And then finally, and this is something that I think is important to consider, more than 2 major organ systems compromised with improvement not expected with operation. And I think this is difficult. We certainly can apply that. Think about how it might apply to some of the patients that we've seen recently in the last 6 months at Emory. Reza will recognize this patient. This is a patient with severe aortic insufficiency, moderate mitral insufficiency, 4 weeks of therapy for aortic valve endocarditis, severe pulmonary edema, came in on 100% oxygen. I told the team if they could get it down to 50% FiO2, I would operate on the patient. We got it down to 60%, and we pulled the trigger to operate. But the CO2 was still 50 to 60. As he went to the OR, the last CO2 was actually 70. We were having trouble ventilating him with pulmonary edema. His creatinine was pushed up from 0.8 to 1.7 with therapy. He had a dense left hemiparesis and had a tracheostomy done 2 to 3 weeks earlier. His left ventricle was good. He also was malnourished with an albumin of 1.6. His systemic pressure was 60 on dobutamine. His wife was a lab tech and certainly understood the situation, and we certainly discussed this with her. But here we have permanent impairment of one organ system. We have severe temporary impairment of the pulmonary renal system. We have nutrition, all not likely to improve in the near term. That is, These were likely to impact strongly his ability to get through the surgery, and we had the surgical impediment of the tracheostomy. Indeed, the comorbidities ended up being fatal, particularly the neurologic recovery never occurred postoperatively, never could come off the ventilator, and decided to stop care after about 3 weeks. Here's another patient, severe mitral regurgitation, moderate mitral stenosis, pulmonary hypertension, and New York Heart Association Class 3 symptoms. This patient is 80, and you could argue that above 75 or 80, that might count as an organ system dysfunction. You've certainly begun to decline, and you have to take that into your consideration. So here, COPD, DLCO2, 30% are predicted. This is without pulmonary edema. Elevated PA pressures, and particularly in elderly patients, I think the elevated PA pressures are important. Severely impaired RV function, but mild TR. Now the RV is not terrible because it can generate a PA systolic pressure of 80, so it's not a terrible RV, but certainly by echo, it was read as severe function. A recent GI bleed with an unknown source, mild portal hypertension and hepatic congestion, chronic renal failure with an estimated GFR of 30 mils per minute per 1.73 meters squared. So here we have severe renal and pulmonary impairment, 2 organ systems out, plus some other factors, the recent GI bleed, RV dysfunction, and pulmonary hypertension, plus 80-year-old. So I think using our risk algorithm, we probably should not have operated on this man. We were again persuaded by the man's mental capacity, the fact that he was eager to proceed, his family was eager to proceed, but if we stack him up against what we've talked about, we probably should not have operated on this patient. This patient did not survive his surgery. This is another patient who did survive, a patient 61-year-old, severe aortic stenosis and shock after multiple VTAC arrest. He had severe aortic stenosis, severe mitral regurgitation, ejection fraction 30%. We don't know what the ejection fraction was before he had these multiple episodes of arrest with CPR and cardioversion. His creatinine was 1.85. He had a shocked liver, but this improved in the CCU. His albumin was 2.1. Newly diagnosed diabetes. He was still on dobutamine and norepinephrine. He was a double valve. He had a low ejection fraction, kidney disease, but the ejection fraction, kidney disease, and liver failure probably would get better with surgery. He's age 61, was operated on, and had a relatively gratifying postoperative course. So finally, in conclusion, we must treat the whole patient, not just the part of the person that's the object of the procedure. And the benefit of the treatment, assessed in terms of benefit to body, mind, and spirit, must be measured against the physical, emotional, and financial cost of the treatment, which is where we're heading in patient-centered value. So thank you very much, and open for questions.
Thanks, Robert, that was a great talk and very provocative for us to think about in this day and age, and particularly with these new technologies available. Just remind people, remotely you can either use the WebEx function to put in questions, or you can use Twitter. That's at Emory Heart. I'll start out with one question. The one challenge we often run into is with the cognitive impairment in these patients, and so I want to know what I know it's listed on your list there as sort of dementia and Alzheimer's, but at least mild cognitive impairment is present in a lot of the elderly patients with AS. And do you do a formal assessment, and sort of what are your cutoffs for, and what's the implications? Is it just because they're not able to participate as actively in recovery, or is that just a marker of general health?
My measure of cognitive impairment that I would include as a organ dysfunction is inability to be independent. That if they are dependent on their family, if somebody has to be with them most of the time, that's somebody who's not independent, and that's cognitive dysfunction. I had a father-in-law who had Alzheimer's, and he crossed the line when somebody had to watch him all the time. He didn't cross the line until that time, but he certainly crossed the line, and that to me is something that unfortunately when we put somebody through a period of extreme stress like surgery, in particular, the open surgery compared to the transcatheter procedure, this usually is accelerated and gets worse. So I think it's something that needs to be incorporated into this.
Okay, we'll start with some questions here, if there are any. Don't forget to use your microphones.
Bob, that was great, and I've always appreciated your appreciation of morbidities and assessment of morbidities. When Vino did that study of our mortality that with AVR, have you got that slide? Or
Can we get?
My question is, did he look at morbidity? And
He did not, because the long-term outcomes that he had were from the Social Security database, and all he could get was the date of death. So he could not look at the return of patients or the morbidity with them.
yeah, one morbidity, for example, that always bothers me is had the operation and went to subacute rehab or acute rehab. That's something I always like to take into account in this situation. So I think that would be very interesting information. For example, if you have a 3% survival, I mean, we know, one thing I say to patients is, we know that we can, in general, get you through the operation. I mean, we can get you back to the ICU, but what happens after that is another question. So, whatever.
Right. The frailty study from Canada did look at that, and they showed that a frail patient was 6 times as likely to be transferred to another institution compared to going home.
Pass the mic to you.
And Robert, when we look at costs in these patients who struggle, a lot of the costs come in the ICU setting. And can you give us any sense as to those patients who may be in the unit for 2 or 3 weeks? What percentage might eventually, get to a point where they have a good quality of life? Or is it possible to say up front, in a large percentage of patients, if you get to these points in the intensive care unit, then you're probably not going to improve? And along those lines, what's the role of getting assistance with our palliative and supportive care colleagues, and what do you see their role as?
I think the palliative care group does a fantastic job, particularly with families, as the patients are in the ICU for even longer than a week or 10 days or 2 weeks. I really think we need to change the name of palliative care, because so many people think, the families think palliative care, oh, the docs are giving up, but we really need to change it to family assistance or something like that.
As you heard me say, I think the name currently is palliative and supportive care. So,
right. Once they hear palliative care, they don't get past that usually, but and neither do our surgeons. Neither do our surgeons sometimes, as far as whether or not the consult should be made. I think that. The thing that's a little confounding is that the critical care docs have data that your chance of leaving the ICU gets better for every day that you're in the ICU. and that's a little odd, but when you think about it, most of the deaths occur in the first few days, more occur on the 4th day than they do on the 8th day, and so our ability to sort this out is difficult, because so many of the patients that are in the ICU on the week are on a positive trajectory instead of a negative trajectory. So I think you need to be looking at maybe at 1 week what the delta is, which way is the patient going. And I think if we are a little smarter about looking at not where the patient is, but which direction they're going at 1 week, then I think. And then also, so many patients do well for a week and they have one setback at 8 days, 10 days, or so forth. And that's the question, is whether or not a major setback beginning at that level is something that we should consider withdrawing treatment once they've had that second major setback, because that's something that's often they don't survive. But that again is something that is the struggle with low frequency events in small numbers of patients.
Robert, I think as cardiologists, we actually have a lot to learn from you guys about factoring in the whole patient, the frailty index, and so forth. My question to you is, where are we with respect to the risk prediction models and their entrance into the guidelines? You mentioned that you guys are proposing this it makes a lot of sense to add frailty index and these organ dysfunction in terms of the STS risk score and the URUS score. Where are we with that, and when will it make its way into?
It's likely that some form of this will be in the valve guidelines that are coming forward this year. The STS database is including a frailty index in their next version. So that it is being included, a simplified frailty index in the next version. So we are moving in that direction, but so in the next 2 or 3 years it should be included.
Well, with that, Robert, well, thank you very much for a very thoughtful talk. That was great. Thank you.
The preceding program is copyrighted by Emory University.